course, I will not inject on the jaw, but I will be using RHA3 with the cannula technique also to fill this mandibular line and the pre-jaw. And at the end, projecting the chin with, again, a multi-layering technique, because here we have deep fat compartments and superficial fat compartments. So the deep bolus technique with RHA4, I will be using a needle. And for the superficial layer, I will be very superficial, even subdermal with RHA4, always blocking the flow of the ascending mental arteries that are always bilateral and coming from the sublingual or the submental artery, but we never found an ascending mental artery in the midline. So they can be bilateral or unilateral, but they have never the same size, the same caliber. There is always one artery which is dominant, and we saw that also in cadaver yesterday with our MENA group of doctors. So Nazila, this is my treatment plan. We will clean the patient.
And thank you, Dr. Nabila. So let's ask the audience, what do you think of the treatment plan? Should we have a show of hands? Who's in favor? What do you think? Show of hands, please. Are you in agreement with the treatment plan? Yes? Thumbs up? Hands? We have a show of hands.
Okay, great.
Thumbs up here. Dr. Kirda, what's your opinion?
Yes, very good assessment, and I'm waiting for the results soon.
Excellent. So we're looking forward to it, Dr. Nabila.
So Dr. Kirda has the challenge to reproduce the same technique with his cadavers in the cadaver lab. So I guess that we will not get the same results because he has more aged patient. I saw his patient yesterday. So
mine is going to be more rejuvenation.
I will use the minimum products that I can use. I will behave with my patient like in my office regarding the budget and regarding also the natural looking result. I don't want my patient to look overdone. I just want to refresh her, to lift, and not to give her volume or a visible volume. Okay, so you can clean her again from the other side. So now that we change the gloves and use the antiseptic, then I can show you how I do also in my practice. You can clean her, please, on the other side. I always use lidocaine with epinephrine for all my entry points because I mostly use a cannula in her case. So I want to inject her like I would like somebody to inject me. So with the less of pain. So that means entry points with lidocaine with epinephrine that will reduce the bruising also. It's okay, thank you. Like insulin syringe in order to make just a papilla.
Could you one more time?
This. And this whitening will help me to see where will be my entry point. Second entry point for the T trough. I know that I will be using 25 gauge cannula, 38 millimeters. So I can use the length of my cannula here to know where will be the intersection between my two lines and where will be the best entry point. And for me, it's here, far from the visible veins. For the mandibular angle, I can place my fingers like this. Essayez de garder la position quand je pousse, okay? I place my fingers like this and I bouge pas s'il te plaît, tu sais? Je garde la position parce que je vais pousser. So I place my fingers like this, and in between, at the posterior border of the mandibular bone, angular mandibular angle, again, just a small papilla like this. Triangles. Remember, mandibular line will be treated with the cannula. So I will have this entry point for the mandibular line and the pre-jaw. When I work with the needle technique, I don't need these entry points. So let's start by the mid-face. For me, it's the central area. I always start by the mid-face and then I go for the temple or the lower face. And even in the mid-face, I start always by giving the support to the fat compartments. And with injecting in the medial souff here, it will also lift the orbital retaining ligament. So I will need less products in the T-trough to fill the T-trough. So here I was using a 23 gauge needle, a blue one. I passed only the dermis, no need to go deeper. And now I'm using teoxane Ultra Deep, which has the highest G prime of the range, which has the best elasticity of the range. So here I'm using a 25 gauge cannula with the length of 50 millimeters, then I can reach the medial souff. I stretch the dermis, I cross the dermis here. When I want to be deep, I will lift up all the skin and the mass and you will hear a click. My patient hear a click. Did you hear a click, Kirdar, in your cadaver lab? Yeah. So my patient can tell you that now I'm on the bone. Look, if I lift my cannula, you cannot see it. But the tip of my cannula is just right here. Now I can start injecting, but I will not inject a big bolus because of safety reasons. Now, in all the areas, you will not see me injecting, even in the temple, a large bolus. There is two reasons. If I'm on inadvertently in a vessel, I don't want to inject in this vessel. So I inject 0.1 by 0.1 or even 0.05. I'm still on the medial souff and you already see the projection that we are starting to have. My patient is very brave, but she's massage because I know that my product is okay. So can we have the frontal view? Zoom in, please. So I was using 0.4 ml in her medial souff. Zoom in. See already the difference between this flat area on the other side and how the nasolabial fold has already her lateral cheekbones, lateral souff. I don't want to give her volume. I just want to have some lights coming here. So I use the same entry point. And again, I pinch and I pass through the zygomaticus ligament. I turn my bevel up. I want that my product lift all the mass and the fat compartments here. 0.05. Changing like by 1 millimeter, checking that I'm on the bone. Because here remember also we have the zygomatical branch of the infraorbital artery. Even if this artery is very deep, she's having this direction, crossing the malar fat and becoming superficial here with 30 perforators for the lateral. But I know that I will avoid it with the cannula. With the needle, you can reach this branch. So a little bit of lifting effect now in the lateral souff. And I was injecting 0.2 ml in this lateral souff with teoxane Ultra Deep. Now I will just change the direction. You see, I'm taking my syringe as a pen. I'm not using the plunger. I will just check the direction, and I will have this direction to the deep medial cheek fat compartment. Lifting again, we have lidocaine with all the products, so the first injection were uncomfortable, but now it's okay? You don't feel? Très bien? Okay, perfect. And now that I'm on the deep medial cheek fat compartment, I inject 0.1 and another 0.1, and it's enough for her. Massaging the products. Sometimes it can be enough to inject in a deep layer that, like we did now. Zoom in, please. Or you can sit. Yeah. Okay. Can you see the difference? Look already at the T trough reducing RH. And on the profile view, we have more projection that we had already.
Dr. Nabila, we will just ask the audience for a show of hands. Is it visible for everyone? Is it visible for everyone? Do you have any questions? No? Okay. It's 50-50.
Okay, so for the 50 that for them that was not enough, I totally agree. I raised my hand with them because it was not enough to work on the deep fat compartments. I want to work also on the superficial fat and to give more definition than that. But of course, I will not do it with our classical filler. I will use a filler that will move and that will follow my zygomaticus major and minor when she will be smiling, and I want a product that will not visible when she will be smiling. So for that, I will be using Teoxane RHA4. And look, Nazila and Kirda, when I want to be superficial with a dynamic product like this, I stretch the skin to me, and it will help my cannula to smoothly slide under the skin. And now you can see my cannula. I can be very superficial, more superficial than that if I want to be. Because of the preserved network and the property of the RHA range that the product will be integrated into the skin, and you have no risk to have a Tyndall effect or a bump or a visibility. So for that, I'm doing retrograding lines. And sometimes we have some like a scar in the mid-cheek groove here. I can even be very superficial like this with RHA4. Okay, it's not her case, but just to show you. I'm feeling all the superficial medial fat compartments of the midface, but not the nasolabial one. And I'm planning to use only half of the syringe of RHA4. So for the first syringe, I use the half. Teoxane Ultra Deep come with 1.2 ml and Teoxane RHA4 the same. So that means that with 0.6 Ultra Deep and 0.6, it's like we have used one syringe on this side only.
Nabila, can you hear me?
This kind of result. Yeah.
You can hear me, right?
Okay.
Nabila, can you hear me?
Yes, I hear you.
Could you also summarize how much amount did you give the medial SUV, lateral SUV, and the deep medial cheek fat bed?
Okay, I was injecting 0.4 ml in the medial SUV, 0.2 ml in the lateral SUV, and almost 0.1 in the deep medial cheek fat compartment.
So you decided patient by patient, right? What they needed or something?
Yeah, we decide with the treatment plan before. I draw it with the treatment plan where I have already a drawing of the face, and we point the number of syringes she needs. So for me, it will be like 1 ml here or 1.2. I mean, 1 syringe here, 1 syringe here, 1 for the T-trough and lid-cheek junction. So that will be 4 here. And you know that for the Texas technique, it's around 5 to 6 syringe with the jawline, chin, and mandibular line. For the temple, I will be using also 1 syringe by side because I'm using a deep supraperiosteal technique.
Thank you.
So now you see, I will use less redensity 2 than I was needing before. Blue needle. And here, of course, there is no risk to inject in the T-trough, especially with a cannula. We'll be using a 25 gauge cannula with teosal redensity 2. So I will not undercorrect or overcorrect with teosal redensity 2. It's already like a sponge, already, full of water. You cannot bring water inside this product. So it will be a correction of 1-to-1. The result you will get today, the result you will see in your patient in 2 weeks. So you see it's not bleeding because of my lidocaine with epinephrine. I will pass through the retaining ligament, the orbital retaining ligament, and look with my non-dominant hand, I avoid injecting inside the orbit. My cannula is on the infraorbital rim. Okay, I turn my bevel up. I ask my patient to look up if possible. You see when she looks up, you better see the hollow. If she closes her eyes because she feels pain, you will see no hollowing. So the first bolus, ça va? So le premier bolus va te donner de l'anesthésie. The first bolus will give her a little bit of anesthesia, of comfort, and then we can slide in. Then I don't inject, I just push my cannula. The tip of my cannula is now a little bit medial to the first one. Without doing any hydrodissection here for lymphatic drainage risks, I just inject 3 boluses. Now the tip of my cannula is here. So I'm not injecting on the nasojugular groove, of course, where is the risk of reaching the angular artery or the nasal branch that coming from the infraorbital artery. So I'm just supraperiosteal. Some doctors recommend to be 2 millimeters above the supraperiosteal layer for this nasal branch, but to be honest, with the cannula, the 25 is so, bigger and no risk to reach, to be inside the nasal branch of this artery here. So look now, I'm just retracting my cannula. I'm not injecting anything. I'm just going back, going subdermally until the lateral contus here to let a nano droplet of redensity 2 in this angle here, this small shadowing that you cannot get with the deep layer technique in some patients. So it's the only area where I will inject just a small drop of redensity 2. And that's enough.
So you gave superficial that area, right?
Just in this 2 millimeter, look, just right here, because I had a shadow that disappeared. Now I will just massage the product from down to up, rolling my finger, not pushing on the bone, from up. Not pushing on the bone because I don't want to let a print of my finger on the bone. And then you can see the result on the T-trough. I was using 0.2 ml. So less than I was planning to for this T-trough. Now we can go for the lid-cheek junction, where we had also a bony resorption, also no more infraorbital superficial fat compartment there. And here in this area, there is no risk of injecting with hydrodissection, I would say. Now what you will see me doing, a little bit uncomfortable at the beginning, but with the product, look, I'm on the bone already. I cannot go further, but what I do is that I will slide on the bone, injecting in an anterograde and retrograde way, especially in my patient who has the thin skin here. Stick to the muscle. Even if the teoxane density 2 is a very soft filler, 15 milligram of a mix of crosslink and non-crosslink HA. Even in some patient, if you perform a bolus technique here, it can be difficult to massage sometimes. So what I do, you see the shadow disappearing.
Show front view camera. Yeah.
So you see I'm creating a layer above the supraperiosteal layer here with density 2. I can go also a little bit in direction of the lateral ligament, and you see my cannula cannot move forward. So I can also have a lifting effect on this ligament in order to open her lateral contus and to have like almond eyes shape. Here, no risk to have lymphatic problems. And for the whole infraorbital area, you have no risk to have any pressure on the lymphatic system because this product do not have any pressure on this lymphatic vessels. So look up. Transition between the lead cheek junction and the T-trough. Here, I can inject a last bolus. Always deep into the bone and always controlling the infraorbital rate. So let me check if I need some touch-up.
How much did you give the lateral part?
It was 0.7 in total for all the infraorbital area. So I see that I need more, especially in these lateral cheekbones that is more enhanced in this side. I will need to smooth the transition between her previous injection. Yeah, so then in total, I've been using 0.9 after the touch-up. Okay?
Yes.
So I can say to my patient that the product will be long-lasting, up to 2 years and sometimes more. Okay? And that also the skin quality will be enhanced by diffusion, even if I was injecting in a supraperiosteal layer. Can you see very well? Do we have some more hands up now?
Yes.
Let's see. So let's ask the ballroom. Yes, we have a show of hands. It's looking good, Dr. Nabila.
Okay. So I'm happy.
Yes, now seen very well. Wonderful result.
Thank you. So let's go for the temple. It takes less time to inject with the needle technique. I like to do it with the cannula technique, especially when I work on the forehead and the temple on the same way. Chlorhexidine, please, clean. Here, my favorite product for the temple is clean, is teoxane RHA 4 again. And I will be using the gunshot technique that Patrick described it in 2010. But I modified it because I like to inject multiple bolus with one single entry point. So here I locate my superficial temporal artery, and you see that she has beautiful veins here. So I want to avoid bruising her. So I will be I can palpate my pulsation between 2 fingers here. And whatever the direction, what I know is to be the deepest possible in contact with the bone. Removing RHA4 from my long needle, you know this is the 25 gauge with the length of 25 millimeter. And this is the needle you find in the blister of Teoxane Ultra Deep. So there is always 2 needles inside this blister. So I keep always these needles for all my deep injections. So the temple is very deep, not only in this patient, but especially also in male patient. This is the reason why I use a long needle. It's always for safety reasons, comfortable reason, because I want to reach the temple, which is deep, but also I want to be sure to be on the bone, because if I use a short needle, I can be on my temporalis muscle. And if give me a short needle. If I'm inside with the short needle, reaching only the temporalis muscle, I will reach the deep temporal arteries, which are running here inside the muscle. So look at the difference between my 13 millimeter of length and my 25 millimeter of length, okay? So if I push this small needle here, when the hollow is important, you will see this plastic part of the needle immediately in contact and pushing on the skin. You will not see the lifting effect that I will get here. So I'm turning the bevel down, going to the maximum of depression between 2 veins. I'm giving this direction because I want the bevel of my needle to be blocked into the bone, and then I can start injecting. So of course, a large bolus with the properties of strength and stretch of my RHA4 will work like an implant and will be easy to stretch and to feel all these muscular fibers that are stick to the bone here. I injected 0.2 only, but I will now change the direction, not injecting anything. Zoom out just to see how I do with the syringe. I just move my needle